Imagine a patient in your practice. Maybe they've tried everything, every diet, intense exercise, perhaps even bariatric surgery. Yet their legs, and sometimes their arms, they just remain disproportionately large, heavy, and persistently painful.
Yeah.
As specialists, whether you're an obesity doctor, an endocrinologist, or maybe a vein expert, that kind of stubborn, resistant presentation can be incredibly frustrating when the usual approaches just don't work.
It absolutely is. And, that frustration often stems from a fundamental misdiagnosis, or maybe just not realizing that what's really going on isn't just stubborn fat or typical edema. It's something distinct.
Exactly. So today we are embarking on a deep dive into a complex, often misunderstood condition, lipedema. And like you said, this isn't just about fat cells. It's a distinct chronic disease primarily affecting the loose connective tissue.
Right. Our mission today really is to arm you, the specialist, whether you're tackling obesity, hormonal stuff, or vein health, with a clear, concise understanding of lipedema. We want to unpack its crucial diagnostic criteria, figure out how to accurately differentiate it from common things like obesity and lymphedema, and explore the current landscape, both conservative and surgical treatments.
Including the latest expert consensus and emerging research, right?
Exactly. The goal is really to equip you with those vital insights for, accurate diagnosis and truly individualized patient care.
And we've pulled from some great sources for this deep dive. We're looking at foundational diagnostic criteria from way back, recent case reports on non-surgical approaches, some direct insights from patient roundtables, and the very latest updated guidelines from key medical associations like the German S2K guideline.
Yeah, good stuff.
So let's just jump right in and unpack this.
Okay, so what's fascinating here is the core definition of lipedema itself. It's characterized by the abnormal accumulation of fat in the subcutaneous region, mostly affecting the lower and upper limbs. But this isn't just an adipocyte of fat cell disease, It's fundamentally considered a loose connective tissue disease. It involves fibrotic components, chronic inflammation, and critically, it's almost exclusively found in women.
And this isn't actually a new discovery, is it? I mean, this condition was first described way back in 1940 by Allen and Hines at the Mayo Clinic.
That's right.
And then a few years later, 1949, they published that really seminal report that laid out diagnostic criteria, which kind of remarkably are still largely referenced today to distinguish it from lymphedema.
Yeah, foundational work. So when we talk about key diagnostic criteria for specialists, clinical observation and patient history are just paramount.
Right.
The first obvious one is that gender predominance.
Yeah.
It's almost exclusively seen in women. Then the fat distribution, it's bilateral and symmetrical on the legs and doorarms, but here's the crucial bit. Minimal or no involvement of the feet or hands.
That sparing is key.
It is. You might hear patients describe it, or you might see it what's called a bracelet effect, or a cuff at the ankle, maybe pillar-shaped legs where the fat affects the whole leg, or even stovepipe arms. This sparing of the hands and feet is a major, major clue.
And for the patient, a cardinal symptom, really the one that truly sets lipedema apart, is persistent pain. Remember that patient scenario from the start. Her agonizing pain, that's exactly what we're talking about here.
Absolutely. This includes pressure pain, tenderness, spontaneous pain, and just this constant sensation of heaviness in the affected tissues.
Now, some guidelines, like that German S2K guideline, state it's always painful, but other sources suggest maybe pain isn't an absolute requirement.
Well, yeah, there's a slight nuance there. The S2K guideline does emphasize pain, but other data suggest roughly 80% of women report pain at a 5 or higher on a 0 to 10 scale. So while maybe not 100% absolute for every single case, according to all sources, it's a huge indicator. It really helps differentiate it. And another critical differentiator from just typical obesity is its resistance to reduction. This tissue enlargement, it just persists despite caloric restriction or even trying to stimulate lymphatic flow by elevating the legs.
Right. It's not just about calories in, calories out. The lipedema tissue itself simply doesn't respond the same way.
Exactly.
So beyond these core diagnostic features, what about some of the more maybe subtle clues that can help confirm your suspicions?
Well, increased vascular fragility is common easy bruising. That's something patients report a lot. Along with the presence of spider veins and telangiectasia, those little dilated blood vessels in the affected areas.
And what about edema? Swelling?
Good question. It's typically minimal pitting edema, and importantly, a negative Stemmer's test.
Can you quickly explain the Stemmer's test again?
Sure. It's where you try to pinch and lift the skin at the base of the second toe. If you can't, it's positive suggests lymphedema. If you can, it's negative, which points away from lymphedema and more towards lipedema or other things.
Got it. Vital distinction there.
Absolutely. You might also feel that the tissue has this distinctive nodular texture. Patients often describe it like frozen peas in a bag or maybe pearls under the skin, especially later on.
But I heard recent guidelines are backing off that a bit.
Yeah, that's right. While it's a common observation, guidelines like the S2K are moving away from using that specific texture as a primary standalone diagnostic criterion, just because it's not universally present or easy to validate consistently.
Okay, that makes sense. So when does lipedema typically show up? You mentioned hormonal shifts.
Yeah, we often see onset during big hormonal changes like puberty, pregnancy, or menopause, or sometimes during periods of weight gain.
And is it always progressive? Does it just keep getting worse?
That's a common misconception. It's not considered a generally progressive disease in a predictable way. Progression really depends on various factors, and interestingly, the level of pain doesn't always correlate directly with how much disproportion there is.
Huh. And what about the skin itself?
Well, the skin might feel cool to the touch and maybe have reduced elasticity, but it typically doesn't harden like you often see in lymphedema.
And there's often a family connection, right?
Definitely. There seems to be a clear inherited component. Patient histories frequently mention relatives with similar body shapes, which suggests maybe an X-linked dominant or autosomal dominant inheritance pattern, but with sex limitations since it's mainly women.
So bottom line for diagnosis and practice.
It's primarily clinical. It relies on recognizing these specific observations and getting a thorough patient history. While, ultrasound and lab tests can be helpful for the differential diagnosis, ruling other things out, they don't actually verify lipedema itself.
So it's really about pattern recognition.
Exactly. It's a diagnosis of recognition based on that clinical presentation.
Which brings us to a really important point.
Yeah.
Why is lipedema so often missed or misdiagnosed, especially by specialists who are experts in related fields?
That's the challenge. It's frequently confused with general obesity, lymphedema, sometimes Dercum's disease, or even chronic venous insufficiency. So differential diagnosis becomes an absolutely critical skill here.
Okay, let's break those down. First, lipedema versus just general obesity.
Right. The absolute key differentiator is that disproportionate fat distribution. It's on the limbs, but without a similarly proportional buildup on the upper body or the trunk.
Whereas with general obesity, fat accumulates more widely everywhere.
Exactly. Remember our initial patient scenario. That disproportion is precisely why her legs stayed large even when she lost weight elsewhere.
And that ties into the treatment response difference too, right?
Absolutely. Unlike general obesity, lipedema fat is remarkably resistant to diet, exercise, even bariatric surgery doesn't really target it effectively. When a lipedema patient loses weight systemically, they often lose more from their trunk.
Which can actually make the limb disproportion look even more pronounced.
Precisely. It highlights that while, yes, many patients with lipedema also have obesity, the lipedema tissue itself behaves very differently. They are distinct conditions.
Which also means BMI isn't the best tool here.
Yeah. BMI, while useful generally, is often an inadequate classifier for overweight, specifically in lipedema patients, because of that high limb volume. The waist-to-height ratio, WHHR, is actually proving to be a more accurate assessment tool for overall adiposity in these cases.
Good tip. Okay, now let's pivot to lipedema versus lymphedema. You mentioned Stemmer's test earlier.
Right. So lymphedema involves significant interstitial fluid buildup. That leads to common pitting edema. You press the skin, it leaves a dent, and usually a positive Stemmer's test.
Whereas lipedema has minimal pitting, negative Stemmers.
Correct. And there's also the who gets it difference. Lymphedema affects both men and women, can be unilateral or bilateral, and it often includes the hands or feet.
But lipedema, almost exclusively women, always bilateral and symmetrical, and crucially, spares the feet and hands. That foot sparing is such a strong visual.
It really is. And thinking functionally, lymphedema swelling often gets better with elevation. Lipedema tissue enlargement doesn't.
Any difference in complications?
Yes, lymphedema carries an increased risk of cellulitis, those skin infections. Lipedema typically does not have that same increased risk. And for definitively diagnosing lymphedema, lymphoscintigraphy is the gold standard to check the lymphatic system.
Okay, two more differentials. Dercum's disease and chronic venous insufficiency, CVI. How do they compare?
Okay, so lipedema and Dercum's disease, they both can involve painful, palpable nodular fat. That's a similarity.
Okay.
But Dercum's, also called adiposis dolorosa, usually presents with more widespread obesity. The painful fat can accumulate on the trunk and really throughout the body, not just disproportionately on the limbs like lipedema. And the nodules in Dercum's can sometimes form distinct lipomas or angiolipomas.
Got it. And versus CVI.
With chronic venous insufficiency, both conditions can have vascular changes like spider veins, telangiectasia, and advanced CVI can definitely lead to leg swelling, what we call lipedema.
But the symptoms behave differently.
Exactly. CVI symptoms, leg pain, fatigue, heaviness usually get worse with dependency, like standing or sitting for a long time, and they often feel better with elevation and compression.
Which is the opposite of lipedema, where elevation doesn't help the tissue size and compression can actually increase pain sometimes.
Precisely. And for CVI evaluation, a bilateral lower extremity duplex ultrasound is really key to look for things like valvular insufficiency or thrombosis. We use the CEAP classification for staging venous disease.
So clearly nailing the differential is huge. Given all this, how often does lipedema actually exist in isolation? It sounds like we need to think more broadly.
You're right. A holistic assessment is absolutely essential because lipedema often shows up with a whole range of comorbidities. It's rarely just about the legs.
What kind of comorbidities are we talking about?
Well, what's really interesting is the connection with other systemic issues. Around 50% of women with lipedema also have hypermobile joints. You can assess that with the Baton criteria.
Wow.
Yeah, and they often have reduced skin elasticity too. It all points towards a broader connective tissue disorder. We also commonly see muscle weakness, postural instability, maybe that hyperlordotic curve in the lower back, valgus knees or knock knees, and ankle pronation.
And these aren't just side notes, they contribute to the patient's overall burden.
Absolutely. They affect comfort, function, mobility. And beyond the structural stuff, there's a significant metabolic and inflammatory component.
Like what?
We see underlying microangiopathy problems with the small blood vessels, that capillary fragility causing the easy bruising, and chronic inflammation. There's evidence for specific markers like certain M2 macrophages, lymphocyte subtypes, elevated platelet factor 4.
So real systemic inflammation.
Yes. And hypothyroidism is also pretty common, seen in maybe 27-36% of cases. Plus, later on, sleep issues like sleep apnea can crop up, adding another layer of difficulty.
And all of this must take a psychological toll.
Oh, absolutely. It's significant. Studies consistently show a high incidence of depression, anxiety, and even eating disorders among women with lipedema. It profoundly impacts their quality of life, their coping skills, their self-esteem.
Which means we really need to be assessing mental health from the get-go.
Definitely. Assessing those psychological factors at the very first consultation is crucial. They can heavily influence how the patient experiences the disease and whether they stick with treatment. In fact, if there are serious psychological conditions present, they really should be addressed before considering things like surgery.
So taking all this together, what's the takeaway for clinical practice?
It really screams for a truly multidisciplinary approach. You can't manage this effectively in a silo. Comprehensive assessment and tailored management need an integrated multi-specialty team.
Like who?
Think vascular surgeons, endocrinologists, dermatologists, definitely certified lymphedema therapists, CLTs, nutritionists, mental health professionals. Everyone needs to be communicating and working together for holistic care.
Okay, so let's talk management. What are the core principles when treating lipedema?
The treatment objectives have to be highly individualized. We're aiming to improve signs and symptoms, maybe reduce limb volume, enhance mobility and aesthetics, and ideally prevent progression. And a key point, earlier diagnosis and treatment generally lead to better long-term results.
Makes sense. Let's start with conservative, non-surgical therapies. What about nutrition?
Nutritional guidance is important, but it's not about crash diets or quick fixes. That often backfires.
Right.
It's about fostering permanent, individualized, healthy eating habits. The focus should probably be on diets that minimize those post-meal insulin and glucose spikes, because those spikes can promote lipogenesis, fat creation, and inflammation.
So things like anti-inflammatory diets, low-carb, keto, maybe modified Mediterranean.
Exactly. Those are often explored. But it's crucial to manage expectations. While weight reduction, if there's coexisting obesity, is definitely good for overall health, it has limited direct impact on the lipedema tissue itself. You lose weight elsewhere first.
Okay. What about medications? Is there a magic pill?
Unfortunately, no. It's important to be clear. there are no specific medications that directly treat the lipedema tissue itself.
So pharma focuses on symptoms and comorbidities.
Precisely. The focus is on drugs or supplements that might help reduce inflammation, fibrosis, swelling, and pain. We generally advise against long-term use of diuretics. They just dehydrate without fixing the root cause.
And avoiding meds that cause weight gain or edema.
Yes, like thiazolid and indones, for example, unless there's a very clear internal medicine reason for them.
Are there any meds or supplements that are sometimes considered helpful?
Well, metformin is sometimes considered, especially if there are metabolic complications, partly because it might have some antifibrotic properties.
Interesting.
Diosmin, often given with hesperidin, is another one. It might help reduce oxidative stress, improve venous elasticity, and act as a lymphagogue, promoting lymph flow, which could potentially ease pain and edema for some. And basic things like monitoring and normalizing vitamin D levels. Also, if birth control or HRT is needed, considering lower doses of sex hormones under careful supervision might be wise.
What about hands-on therapies? Manual lymphatic drainage, MLD.
MLD plays a role, but primarily for pain reduction. It seems to modulate C nerve fibers. It's not typically expected to cause dramatic reduction of the lipedema fat volume itself.
But it can be part of a broader manual therapy plan.
Yes, absolutely. It can be combined with other, maybe deeper techniques like soft tissue mobilization or myofascial release. These are important for tackling those fibrotic restrictions and improving tissue pliability, but always done with patient tolerance in mind. It can be painful tissue.
Makes sense. Compression therapy, is that just for lymphedema?
Not at all. Compression is indispensable for many lipedema patients, mainly for pain reduction and providing comfort. It supports the tissues and helps manage any coexisting edema.
But it doesn't shrink the fat itself.
Correct. It does not reduce the adipose tissue volume directly. It provides crucial external support. And compression needs are super individualized.
So not one size fits all.
Definitely not. Selecting the right material, circular knit, flat knit, and the right compression class level, usually class 1 or 2, depends entirely on the individual's symptoms, their limb shape, and crucially, their tolerance. It's not based on some fixed disease stage. Sometimes layering garments is needed.
And proper fitting is key, I assume.
Essential. Needs to be done by a trained professional. Regular wear and diligent skincare underneath are also vital to avoid chafing or breakdown.
What about those pneumatic compression pumps?
IPC.
Intermittent pneumatic compression, yeah. That can also be quite effective, again, for pain relief or reducing associated edemas that might be there from comorbidities and maybe improving capillary fragility. And it's something patients can often use at home.
And exercise? What's recommended?
Exercise programs should always be tailored and progressive. Start slow, build up as tolerated.
Any specific types? Generally, low-impact activities are best. Things like swimming or water exercise are fantastic because of the buoyancy and gentle pressure. Elliptical machines, yoga, stationary bikes, whole-body vibration platforms, and just plain walking are also great.
What's the goal with exercise?
It's about maintaining mobility, promoting lymph drainage, improving flexibility, posture, and strength, all without putting excessive strain on those sensitive tissues.
Okay, so we've covered a lot of conservative strategies, but for some patients, these aren't enough, or maybe the disease is more advanced. What's the role of surgical intervention, specifically lipedema reduction surgery or liposuction?
This is a really critical point. Liposuction, when performed correctly for lipedema, is currently the only available technique that can sustainably remove the abnormal lipedema tissue.
And you mean not just the fat cells?
Right, not just the adipocytes, but also the nodules, the fibrotic extracellular matrix, and those other non-adipocyte components that make up this diseased tissue. It's a different goal than cosmetic lipo.
And I think you mentioned earlier it might affect progression.
Yes, crucially, it's also the only treatment currently known that seems to have the potential to slow the progression of lipedema. Ideally, it's performed before severe complications or significant disabilities develop.
What techniques are used? Is it different from standard liposuction?
It uses specialized techniques like suction lipectomy, sometimes excision, maybe manual extraction, but always with meticulous care to spare the blood vessels and, importantly, the lymphatic vessels. Recommended methods often include tumescent liposuction, water-assisted liposuction, or WAL, and power-assisted liposuction, or PAL. There's actually limited specific data on using laser or ultrasound tech for lipedema itself.
So when is surgery actually indicated? It's not for everyone.
No, definitely not. Key indications would be things like documented refractory pain that hasn't significantly improved despite a good trial of conservative therapy.
Call it functional issues.
Yes. Complications like severe impairment of mobility, maybe secondary skin problems like recurrent infections and folds, or related orthopedic diseases getting worse because of the limb size and shape.
What about weight? Does BMI matter here?
It can. Surgery might be considered a critical indication for patients with a BMI over 40 and a waist-to-height ratio over 0.55, but, and this is crucial, liposuction for lipedema is not a method for general weight reduction. That needs to be addressed separately.
So treat coincident obesity first, and any edema.
Yes, prioritize managing obesity and getting any coexisting edemas decongested before surgery. There's also usually a strict indication for considering surgery in patients younger than 18, meaning it requires very careful consideration. And generally, surgery should only be on the table after the patient has shown they can comply with or have truly failed conservative therapies. It's a significant step.
And pre- and post-op care must be vital.
Absolutely crucial for success and minimizing risks. Before surgery, screening by a certified lymphedema therapist for prehab is great exercises. Manual therapy, getting compression garments sorted.
What if they have lymphedema too, lipolymphedema?
Then intensive pre-op volume reduction with complete decongestive therapy, CDT, is strongly suggested. And standard pre-surgical workup like venous thromboembolism, risk assessment, maybe using the Caprini score, and definitely a pre-surgical venous duplex ultrasound are important, especially if they have varicose veins or other venous issues.
And after surgery?
Immediate complex physical decongestion therapy is vital. The intensity and duration will depend on how things look post-op. And it's not over then. Continued conservative treatment focusing on mobility, keeping weight stable, managing stress that's necessary long-term because surgery doesn't cure lipedema. It manages the abnormal tissue burden.
Right, it's ongoing management. What are the typical outcomes? And the risks?
The benefits can be really significant. Patients often report major improvements in spontaneous pain, pressure pain, that easy bruising often gets better, plus improved mobility, physical function, and just overall quality of life.
Does it reduce the need for other therapies?
Often, yes. It frequently reduces the need for ongoing intensive conservative therapy, and even in more advanced stages, significant symptomatic improvement has been reported.
Are there limitations?
Sure. Liposuction might be less effective at reducing shear volume in very advanced stages or in the context of severe obesity. Sometimes large sacs of loose skin and tissue remain, which might eventually need a separate surgery like a dermal lipectomy to remove.
At risk.
While generally rare with experienced surgeons who specialize in this, potential risks include things like anemia, especially with large volume liposuction, venous thromboembolism, blood clots, pulmonary embolism, and of course the risk of lymphatic injury if not done carefully.
Okay, so wrapping this up, what's the main takeaway from this deep dive?
I think the main message is that lipedema is a complex, multifaceted disease. It demands precise differential diagnosis. You can't just lump it in with general obesity or swelling. And it requires an individualized, integrated, multidisciplinary approach to care.
Understanding these nuances is really critical for improving patient outcomes and their quality of life.
Absolutely.
And this field is still evolving, isn't it? What's on the horizon?
It is. There's a lot of ongoing research trying to better understand the underlying pathophysiology, really nail down the mechanisms behind the pain, and develop more objective diagnostic tools. Wouldn't a reliable blood test be amazing?
That would be a game changer. So there's still much more to learn.
Definitely. It's an exciting, if challenging, field.
And maybe a final thought for our listeners as they reflect on their own practice.
Yeah, maybe consider this. How many patients have you seen with that stubborn fat, that unexplained pain, or that really disproportionate limb size, who might actually be living with undiagnosed lipedema?
It's a challenge, isn't it? To think about how applying this deeper understanding, these specific diagnostic clues and tailored treatment pathways we've discussed, could truly transform your approach to these difficult cases.
And potentially unlock much better health and quality of life for those patients.
A really important consideration.